Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Robert Hudeck from Germany. Dr. Hudeck completed his residency at the Belgrus University Hospital in Switzerland with Professor Gerber. He worked at the Division of Upper Extremity Surgery at the Round Klinikum Bad Neustadt in Germany with Professor Frank Olke. He has been Deputy Chief of the Department of Shoulder and Elbow Surgery at Bad Neustadt until recently when he moved to the ATOS Clinic in Hamburg, Germany. He's a member of the European Shoulder and Elbow Society and reviewer for multiple journals, including the Journal of Shoulder and Elbow Surgery. He has received several research grants and has published in multiple journals, including the Journal of Shoulder and Elbow Surgery. And he has several book chapters to his credit. So today, it's my great honor to introduce you to Dr. Robert Hudeck from Hamburg, Germany. Over to you, Robert.
Yes, Hitesh, many thanks for the invitation. It's really a great honor to have this lecture and to be on your program, which is really astonishing. I absolutely congratulate you to such a program, which is, I think, unique in the online education world. So the topic today is revision shoulder arthroplasty, and maybe one remark up front. So I was working for over 10 years with Frank Olke, who was my chief and head of the department in the Rhön Clinic in Bad Neustadt, but I quit recently there, and I'm going to move to a new clinic, which is in Hamburg, also in Germany. So, but all the cases I'm going to present and all the pictures and graphs I'm presenting are from my old clinic in the Rhön Clinic in Bad Neustadt, which is a great clinic for shoulder and elbow surgery, and with great staff and great people, they're doing a good job. So let's see. Okay, so I have nothing to disclose. So this is a picture from the German Shoulder Arthroplasty Register. It was very recently published by Jörn Kircher this year. And here you can see the primary shoulder prostheses are raising and raising. And this is just a fraction of the prostheses implanted in Germany, because the register is on a voluntary basis. It's not that you are forced to put your data in, but you can do so if you want to. So this is only about 10% of the prostheses which are implanted, but it's quite a good number to show you the development of the implantations in Germany. And the the lower graph is the revision prosthesis, which is also raising, but not as sharp as the primary are. And these are data from France. This is a time span overlooking 20 years, which is huge. It was also recently published by Olivier Gauchy. And this is the numbers from 2 French centers. And you can also see here primaries are raising pretty sharp, and the revisions also a little bit raising, but not as much as the primaries. So why is that so? It could be because we see hemiarthroplasties over the last 20 years are going down. So they had their best times in the late 90s, but right now hemiarthroplasties is not so modern. People don't like to do them anymore, and I can tell you why is that so. And total shoulder arthroplasties are staying quite constant, and in recent years they have a short decline. But the reverse shoulder arthroplasty, they have a steep, very steep increase. And here are numbers from the Australian registry. So, and these numbers are very good because they are all the prostheses from whole Australia are in there. So that's pretty good numbers for evaluating shoulder prosthesis and also other prostheses as well. So you see here more than 180% increase from 2008 to 2019. And on the right side, you can see that the reverse are going up very steep and the anatomic are going down. So it could be because you see anatomical shoulder prosthesis, how do they survive? They do pretty well. So there's numbers from 2005 from Deschmuck. They're showing that more than 80% are still in after 20 years. And other data say that after 10 years, 96% are in. And the reverse are also doing quite well, 87% after 20 years. Published in 2017. That's also a pretty good number. But the problem seems to be if you implant a reverse in younger people, that means under the age of 60. And that's only 60% of them are still in after 20 years. So what's with HEMIs? Well, HEMIs are pretty easy to implant. There's no glenoid to do, but the HEMIs have one big problem, and that's glenoid erosion. And you can see that here. These numbers were published from William Levine in 2012. So after a long period of 17 years, only a quarter of the patients who have a HEMI are satisfied with their results. So they're deteriorating. They don't get loose. They don't make too much trouble, but they do a lot of pain. And this is because of glenoid erosion. So, and this was shown by Birgit Werner in 2017, and she showed that on radiographs, how the erosion is progressing on the glenoid. So in the first 5 years, they have strong progression in glenoid erosion. And then they get to a stable part. And once you manage to be okay with that, you can stay with a HEMI for a long time. But many patients, they get bad in the first 5 years. So why do anatomical prosthesis fail? So there's lots of reasons. There's infections, instabilities. You can guess anything you can imagine. But the major problem, the biggest problem in anatomical total shoulders is definitely glenoid, and that's glenoid loosening. That's by far the #1 reason why they fail. And this was shown by a study group from Rick Mattson, USA, by Papadonikolakis, and he showed that 1.2% is failing, glenoids get symptomatically loose per year. So that's quite a huge number. And this is the data from the Arthroplasty registry for the German one. And you see here loosening, total shoulders, anatomical, is almost half of them, they get revised because of loosening. And in reverse shoulders, it's a little bit different. You have many different reasons here, like dislocation, glenosphere problems, chronic infections, and so on, but they are quite equally distributed. And well, the reverse has also some problems. They get also loose and unstable, but infection seems to be the biggest problem in the reverse. As you can see here, that's data published from the Scandinavian registry. And this is the Kaplan-Meier curve for reverse shoulder arthroplasty for a primary reverse, just simple cuff arthropathy reverse. You see after 10 years, more than 90% are in. But you can see one big difference, and that's a difference between males and females. So males do much worse than females. That's strange. Why is that so? And another study, also from the Scandinavian registry, shows they compared anatomicals and reverse regarding infections. And they found that the reverse has almost 2.4 relative risk, higher relative risk than an anatomical for an infection. And you see here, male gender also twofold greater relative risk, and also younger patients. So reverse, male and young. That's a bad combination. And this could be maybe because of Cutibacterium acnes. We have heard about this already on this program. There was a great lecture about Cutibacterium. And one thing it could also be, we found that in an old study published in 2013, where males had a relative risk which was 2.5 times higher than females. And also the approach is a problem. So if you go from anterolateral, you have more hair, as you can see on the right picture, more follicles, and therefore you find Cutibacterium much more often. And this is an interesting study also done here from Fadnes and Lee, and they disinfected the shoulder and took they took swabs before, after disinfection, and then during surgery. And you can see before disinfection, C.ACNES is there in 42%. After disinfection, it gets less, but not completely away. But then you incise the skin and you have more as you had before disinfection. And even if you take a biopsy, it's still in there. So this is because C.ACNES lives very deep in the sebastiofollicular unit underneath the skin. So you can do whatever you want. You can disinfect. And there's new studies showing that benzoyl peroxide is helping, but you have to address it 2 weeks before. So usually it is not a pathogen in the normal setting, but if you dislocate it to the deep layers, it might get a problem. But I can tell you, it seems to be that the problem is much bigger than anticipated, because there's a very recent study published this year, and it seems that it is living in the shoulder even before the surgery comes. There was a huge research team, international team, European team with microbiologists, pathologists, and We did shoulder arthroscopies, first-time shoulder surgeries, took a specimen from these regions from the intra-articular tissue and did immunohistochemistry, stained it with C.ACNES specific antibodies, and it was almost everywhere. So in the joint, intra-articular, never done surgery before, shoulder arthroscopy, almost 70%. And if you look much deeper with a fancy microscope, a laser scanning microscope, this is a macrophage, the red points are C.ACNES, it is intracellular, which is quite amazing because it could be that it is also there before. But that's other thing, but it has clearly to do something with revision shoulder arthroplasty. See also a 3D image. Blue is the cell nucleus and red is C.ACNES close to the nucleus, so it must be intracellular. Okay, back to revisions. It's a big problem. It's a complex problem. And the big guys in shoulder surgery already admitted that it's a supreme challenge for the experienced surgeon, and Charles Rockwood also stated it's technically challenging and the overall results are inferior compared to other procedures. And it still is. It has nothing changed about this. Maybe the reverse is getting it better, and you can see the reverse is the absolutely workhorse for revision shoulder arthroplasty. So almost any revision you do, you will end up in a reverse. You see here on this picture, primary reverse are raising as well, but also the reverse for fracture sequela, the reverse for TSA revision, reverse for reverse revision, and the fracture reverse, all are raising. But even with the reverse, there's limitations, and this is when you do not have enough bone stock in the distal part, like in this case, where the humerus is completely destroyed in the distal part. So then you have to you do a total humerus with the elbow included. Okay, so but what to do when you have to deal with a revision? So the first and the biggest point is indication and analysis. So what's the problem? Is it an infection or is it maybe a mechanical failure? How big is the bone loss? So you should definitely use CT scans. And what about the soft tissue? So is the delta, the axillary nerve, because most of them had prior surgery. So is it intact? What about the rotator cuff? So all these things matter, and they go into surgical planning. So these things determine what type of implant is to be used. How much bone do you have left in the humerus? Can you take implant from the shelf, or should it be custom made? Do you need allografts, or can you take an autograft from the iliac spine? And is the procedure so big that you need 2 steps, or can you do it in 1 step? So that's the planning procedure. And then comes the surgery. And the surgery sometimes is kind of a surprise. So whatever you've planned, it could be that you will be surprised by any circumstances you have to deal with. So for instance, you thought that the implants are pretty fixed and well, and you open up and everything is loose. So you have to take out and do a spacer. And you have to play a little bit with your experience and with the things you find there. And then, of course, in these big revisions where you have long stems, the reposition of the humerus is a quite difficult procedure. Okay, so why do total shoulders fail? So it's cuff insufficiency, that's for sure. You have erosions on the glenoid, you have defects in the glenoid, you have also humeral loosening infections as well, and you have nerve lesions, like in this case. This is a young lady. She had an osteosarcoma tumor, and there's a HEMI inside, but the delta is completely gone because the axillary nerve is totally destroyed. So this case, you cannot change to a reverse, because if you do this, it will get loose and it will be unstable and you will have dislocations all the time. There's no force to keep the shoulder inside. So this is something you have to tell the patient. So the soft tissues and the delta is weak, you can't do it. And why do reverse fail? So there's many reasons. Also nerve lesions, instability is a major reason, infections as well. And maybe for the reverse, a very special thing is the acromion fracture. This is a quite often problem if the tension of the delta muscle gets too strong and the inferior image shows this clear acromion and spine fracture. So these are data. One is from France, from Pascal Beaulieu, the other is from my boss and mentor, Frank Golke. Instability, infections are quite common with the reverse, and humeral loosening. These are numbers from their departments. Technical errors are also there, but not as common as instability, infections, and humeral loosening. So these 3 points are the major causes of revision and failures in a reverse. So if you have a short stamped implant or a stemless implant, that's quite easy, or well, I wouldn't say easy, but it's in comparison to the others, it's a quite nice procedure because you have enough bone stock. You can remove the metaphyseal part and the head, and you have still enough bone even to put in a short stamped implant like seen here on this image, and it was converted to a reverse. So if possible, in primary shoulder arthroplasty, it's definitely good to have implants that are stemless or short stem to plan for further revisions. Okay, so let's come to a case. When to revise. This is a patient, he's 80 years old now, and he was implanted almost 20 years ago with an anatomical shoulder prosthesis. As you can see here, there's huge osteolysis around the humeral part beneath the head. He has pain since 3 years, but he can move the arm pretty well. But you can see on the radiograph that the poly is pretty much down. And if you do an arthroscopy, you see something you did not see on the radiograph. You see huge pistoning. So it's all moving up and down. So this is something to be revised. And the patient agreed to the revision, and the stem was quite good, so it could be converted to a reverse, and the glenosphere was implanted in a one-step procedure with allograft, as you can see here on this page. And the allograft was quite good to fill the gap of the hole in the glenoid, and it could be fixed pretty well. So this is a case that waited too long. She was also 13 years after her implantation. She came, and you could see on the radiograph, the poly is pretty much down, but she was quite doing well. She had not too much trouble, so she didn't want to have the surgery. And she waited for another 3 years. And you can see between 2011 and 2014, there's a huge difference. And she waited too long. And the CT scan shows that there's so much osteolysis. The defect is too big. And on the right side of the image, you have a 5-degree bone loss on the glenoid. You cannot do this in a one-step procedure. So she needed a much bigger procedure. She needed a 2-step revision, autograft from the iliac spine and the spacer. You can see that on the CT scan, there's the iliac spine, and then she was revised to the reversed on the lower image. So what about metal back? Well, metal back, you can see that on the left image, they have a pretty big polyethylene wear. And that's the biggest problem of the metal back. You can see the typical wear on the right image, and also you have a little bit much bigger offset because you have the metal back part plus the poly, and this makes more stress to the rotator cuff because of lateralization. And this is also demonstrated by this study, also from the Rick Madsen group from the USA. They checked for revision reasons for all polyethylene anatomicals and metal-backed anatomicals. And the conclusion of the authors is pretty clear. They do not encourage the use of these glenoid components because of the huge wear and the much higher revision risk shown in this study. So this is a case. Also, metal-backed glenoid. It's a metal-backed prosthesis, anatomical, implanted 16 years before. This is quite a good time. 16 years for an anatomical is not too bad. But look at the osteolysis. It's huge. And the arrow in the middle indicates the remnant of the metal part of the glenoid. So it's also, there's not much left of it. So the poly is completely down. So the patient was moving just metal on metal. And you have huge osteolysis. So what to do? It's an allograft reconstruction is definitely necessary. You have a huge hole in the glenoid and in the humerus. And you can see here on the right picture is the CT scan after the bony augmentation, after the bony repair of the glenoid. So almost all the glenoid is repaired by an allograft bone graft because there was nothing left from the glenoid. Here, the CT scan also shows the huge bone graft and only a small remnant of the base plate pack centrally in native bone. So what to do with the humerus in this case? So this is nothing for a standard prosthesis. You do not get the length and you do not get the distal locking because you need a stem which is very long and you have not enough anchorage in the distal part. So this was a custom-made prosthesis. It was planned according to the CT data of the patient. and it was produced according to these data. And it has, as you can see here on the right image, a distal locking screw and also an allograft in the stem, in the central and proximal stem for the soft tissues to adhere. So this is the patient 6 months postoperatively. Everything seems pretty well. And this is the patient, he's moving 6 months postoperatively. You can hear my boss, Frank Golke, in the background. He did the surgery. And this is I would say, extraordinary good case. So this is something you can show, because this patient, he's quite thin and he's sportive and he can move very well. And he was definitely operated quite perfectly by Frank Golke, I'm sure. And you can see even the internal rotation is quite good. This is not normal for a revision case in this amount. So what to do about glenoids? So the harvest of the glenoid, of the bone block, is best done if you have some humerus left. But this is only the case if you have it. So in the revision case, in most of them, you don't have it. So you have to take an allograft or something else. And here you can see quite nicely, the bone block is put underneath the base plate to augment the defect. And in this case, in a revision case, there was a huge hole in the glenoid, and you have to take a femoral head allograft for the bone block. But you can also take an iliac spine, but the amount of bone you can get from the iliac spine is quite limited. So you can get some thin parts, but you do not get too much of the allograft. But you could combine it. You can combine an allograft plus autograft bone, because the biology from on bone is much better and promotes healing much better than an allograft. But here in the next picture, you see what happens if you take a block which is too big, especially in elderly ladies and rheumatoid ladies. So I would encourage you to put on a plate on the iliac spine after you've harvested a quite big bone block in elderly ladies, because this is what definitely can happen. It's just a matter of time when this would happen. And what about the base plate? So the base plate needs to have a long pack. It doesn't matter which manufacturer you choose, but this is, for example, a custom made. It's 30 millimeters. Those from the shelf are 25 millimeters, which is in most cases sufficient. But this is according to planning. You know, if you have a case where you definitely bigger packs, you would have to ask for a custom-made one, because the other ones are not long enough. But you definitely need a long pack. That's a must. Okay, this is why you see the graft. The iliac spine is here underneath the base plate, and only a small part of the remnant central pack is left. So the implantation point is about 12 millimeters from the inferior part of the glenoid. If you do not have navigation, this is poor man's navigation, which is pretty good, and it works quite well. This is from a very nice publication from Tom Norris from the USA. I just would like to encourage you to read this publication, because it says you almost anything about revision surgery and tips and tricks and techniques. It's a very good thing to learn from. And the base plate is put here. You can see that on the right image, flush with the inferior part of the glenoid, which should be done in primary cases, but also in revision cases. This is also important, that you put the glenoid base plate flush with the inferior part. So the safe zone in the posterior part is about 1.4 centimeters, also from the Tom Norris publication. And on the right side, you can see the screw positions. I wouldn't tell you more about this. You can read that in the publication quite nicely, where you have to put the screws. And this is because of the suprascapular nerve, which is running in the superior part. So you have to take care with the screw directing upward and the coracoid base, and the posterior screw and the inferior screw, because of the branches of the suprascapular nerve. Okay, so what's the anchor principle? It's the base plate here, and the central post is in the middle, and the screws on the side are angularly stable screws. And these three things, they hold the construct. So it is not yet perfectly defined, but biomechanical data indicate that about 10 millimeters, if you have 8 millimeters and you can't get more, you can try with 8 millimeters, but it's good. It would be good if you had about, let's say, 10 millimeters of remnant native bone stock, where you can put the central pack of the base plate in. So which allograft to choose? Well, the best one is the fresh frozen one. So the biology and the integration of fresh frozen allografts are definitely better than the dried ones or chemically inactivated ones, but it depends on which allograft you can get in your place, in your country. So there's some political regulations that say you cannot use fresh frozen allografts because they have to be chemically inactivated, and those are a little bit inferior biologically to the fresh frozen. So if you can get a fresh frozen, get a fresh frozen. Here you can see the graft is drilled out of the bone and then shaped according to the size and the match you want to have according to your planning. So what about defects in the glenoid? So you have 5 grades. 5 is the worst, and it starts with 1. So 1 and 2 are okay. You can do that in most cases with a one-step procedure, but if you go into defect 3 and 4, you should consider a 2-stage procedure because the defect size gets too big. And if you are in a grade 5 defect, you definitely need a 2-step revision. This is presented also quite nicely by the paper from Frank Oike written in 2017. So this is a case where one-step procedure is okay. This patient came to our department because of pain and functional loss in his shoulder. He was treated in another clinic, and you can see here the reason. It's a mechanical reason, so the reason doesn't seem to be an infection, so infection parameters work quite well, but you can see that on the radiograph and the CT immediately. The superior tilt of the glenoid is extreme, and this is the reason why it doesn't work and why the rotator cuff is going to fail. So there's a revision possible in a one-step procedure with a fresh frozen allograft. You can take out the glenoid, and if the remnant hole is not too big, you can just put in the bone and you have a one-step procedure. A different case is with infections, like in this lady. She's pretty sick, and you can see that redness and swelling, and there's a chronic fistula in the axilla. So this prosthesis is totally infected. And it has to be taken out completely, including all the foreign materials, which has been done. So not only the humerus has been taken out completely, but also parts of the glenoid, which were also infected. And you can see here, the cement is mixed with 3 different antibiotics, vancomycin, meropenem, and gentamicin. And not only on the humeral side, but also on the glenoid side as well. The spacer stays in there for about 6 weeks, up to 3 months. And then it's according to the clinical presentation and the laboratory parameters. So if the CRP is quite okay, you can go over to the second revision, which means that you take out the first spacer and you put in a second spacer, plus you augment the glenoid with a fresh frozen bone. You cannot do this in the first procedure because there's bacteria everywhere. You have to wait until the infection is resolved, and then you can put in the glenoid augmentation, which was done here in this case. So you can see 3 months after the second operation, the CT scan, the defect is augmented with bone. So there's also a huge allograft taken and fixed with 3 screws in the glenoid. And the rest of the bone, if you have some remnants of the femoral head you're taking, you can mince them and put all the stuff together here. The arrow indicates it in the glenoid cavity. And then after everything is healed, so it takes another 3 months and antibiotics for about 4 to 6 weeks, the revision stem can be implanted. So what about the humerus? So we had glenoid defects, now we're going over to humeral defects. So there's also five type of grades of humeral defects. And they're basically divided into soft tissue attachments. So grade number 1 is not so bad. Grade 2 is a little bit worse, but not as bad as grade 3 because the pec major and the latissimus dorsi and teres major are missing in these scenarios. So you can say, as a rule of thumb, if you have a grade 3 defect, the outcome drops like a stone. And if you have a grade 3 defect or higher, you should definitely consider putting in an allograft, like shown on the photograph here, down here, for the proximal humerus. So don't leave the stem naked. Put proximal humerus allograft around it so the soft tissues can better adhere. This is important because if the soft tissues adhere to the allograft, you have less torque on the stem, which is very beneficial. And you don't have that if you have just the bulky metal. So how about the stem? If you can't get it out, you have to do a procedure. It's described as the transhumeral approach. So you leave the attachment of the packed major on the bone, and you make a U-shaped incision with the jigsaw, and you open it like a window. And so you have still blood penetrating through the bony window, and you can put it back. So then you open it up like a book, and you can take a jig and a saw, and you can take out the prosthesis. And it's important to get out all of the cement rests and all of the foreign bodies out of the stem. This is a picture from an intraoperative case. You can see here on the right side, the bone is opened like a book, and you can take out the prosthesis. So what about these long stems? How do they perform? So this is a study written by Birgit Werner, 2017, and they are doing quite well, but in 12%, something interesting is happening. They are migrating. They're migrating, although they are cemented, they're migrating downwards step by step. And in this case, over the course of 10 years, there's a migration of 18 millimeters. So they get loose, and you have to revise them, not definitely because they're loose, but because they're penetrating the posterior cortex of the distal humerus, like you can see on the inferior image. And it has been revised to a custom-made implant with distal anchorage of 2 screws. So tumor prosthesis is a difficult chapter because it's so much bulky metal, the soft tissues don't adhere. And this is a case with a chronic low-grade infection, multiple prior surgeries, and this is absolutely hopeless. You can't do almost anything any longer. So you can only do a total humeral exchange, which is a huge procedure with high risk and a very bad function. Okay, so tumor prosthesis, there's a high risk of instability, whatever you do. Even if you do the correct length and you put them quite nicely as you planned them, they still can get loose pretty much. And this is because the soft tissues don't adhere. So even if you take Dacron mesh tissues, whatever, they just don't adhere because it's too much bulky metal. And all the low-grade Cutibacterium bacteria I have told before, who are probably living there for many, many years, they love foreign material, and these bulky metals are immediately full of Cutibacterium biofilm. So, and over the course of several years, they make a low-grade infection and loosening. So that's the big problem of tumor prosthesis. And the distal anchorage is also a problem. Look at the humerus. It has a curved distal part, but you can't see that in the tumor prosthesis shown in these images. So there's definitely a thing the industry has to think about. Okay, so distal curvature is important in a very long stem. And the distal locking screws seems to be quite a good concept. It's a 2-incision approach. So there's a delta pectoral approach from the front, the prosthesis is put in, and then you put the patient a little bit to the side, and you go to the back of the elbow. You go here, make a small incision, and you put in 2 screws under fluoroscopy. You can do that over a bony window, or you can just do that with a skin incision and look for the holes with the fluoroscope. This is a case, also chronic C.ACNES infection in a male patient, and he was loose in 2005, and he was revised to a long stem revision, long stem, which also got loose after 8 years, and it was a Cutibacterium infection all the time. And then he was treated with a cement spacer and ended up at the end with a distal locking custom-made implant, which is still intact and good, but the function is, I would say, moderate, low to moderate. Okay, so the next generation system for revision arthroplasty, because the revision will come, it's just a tsunami that will roll over us because all of the primary shoulders that are implanted right now, And it has been developed mainly by Tom Norris, Wayne Burkett, and Frank Goelke from Bad Neustadt. And it's an adjustable system. So you can use several sizes of stems with different heights. So you can adapt intraoperatively to the height you have planned. So you don't have one stem which has to fit. You can adjust several heights, and it's adjustable. It's fully coated, and you can. And it's the proximal part has also a flexible rotation. So this is definitely a good revision implant. And but it's not good for everything. Like in this case, an 84-year-old lady who was operated multiple times because of a failed fracture, and then she had a HEMI, and then she was revised to a tumor prosthesis in another hospital, and then she was referred to our place with the picture on the left side with a broken out tumor prosthesis. Well, and the remnant length in the humerus is too low. You need a custom-made implant with distal locking screws, as you can see here, plus overgrade 3 defects. So an allograft in the proximal part is also put in for the soft tissues. So here's the algorithm for the humerus. So type 1 is okay. You don't need an allograft, and you can almost take any time a standard or short stem even. Type 2 is you need about 100 millimeter stem, but no allograft. Sometimes you can think about a latissimus dorsi transfer, but not in every case. And then we come to the grade 3 defect. So pect major is missing, latissimus dorsi is missing, and you need definitely a revision stem, and an allograft becomes questionable. Yeah, so you should definitely think about it. But in type 4 and 5, you definitely need it. And in type 5, usually a modular custom-made system with distal locking screws is mandatory. Okay, let's look at the common problems in revision reverse. So the arm length is a major problem. So you should have a radiograph of the healthy contralateral side to measure the distance of the humerus to adapt the humeral length on your prosthesis, on your revision side. So you aim at the length of the contralateral side. So the components are often too small. So if you can get in a big glenosphere, try so and do it, because it gets more stable. And the humeral stem is often too short, and then the anchorage gets weak and it breaks out. And often there's a malrotation, and sometimes the center of rotation is too much medial, because there's not in every case an allograft used, and the bone, if you have a rheumatoid patient, is very weak, and the center of rotation of the glenosphere gets too medial. That's also a problem we see in heterotopic ossifications, of course. That's not too often, but sometimes you see it. Okay, let's get to this case. It's a 76-year-old lady. It was a classical osteoarthritis planned on 3D with CT scan prior to surgery. And the implant was put in. It looks quite okay, and the patient performs well, but she has some pain all the time. She complains of pain, but we didn't see anything. CRP was always good. Meanwhile, we did the contralateral, the left side, also with a reverse. She's super happy with the left side, and she can move the arm. Good, the position is quite well, but she says, well, you know, still I have some trouble with the first one, the right side. It's okay, but not perfect. Can you look at it? So we did a radiograph. As you can see here on the left side, CRP is normal. Absolutely no signs for an infection. She has quite a good function, but some pain, and we do not really know why. So what did we do? We do a CT scan. And now you can see in the CT scan what you didn't maybe see on the radiograph. So the base plate is completely loose. There was quite not a perfect explanation for that, but the glenosphere is loose. I operated this patient in the first time, and we didn't really know why. Maybe it was a technical error, but I definitely cannot say anything wise to it. But the stem is well fixed. So what to do? Well, it's a grade 1 is maybe too low, but I think it's a grade 2 defect. It could be that we can solve it in a one-step procedure. So we ordered an allograft, and it didn't look like an infection. Still, we debrided everything, took multiple specimen from different parts of the place, but it didn't look infected. After jet lavage with Lavanit, which is a disinfectant solution, and water in a solution, we were able to put in another base plate and a glenosphere just with a bony augmentation from femoral head allograft. Impaction of the bone graft into the holes, found a new place where to put in the base plate of the glenoid. So the bone stock was sufficient, and it was possible to do that in a one-step revision. So this is a case which quite happens all the time, and maybe you will land into this yourself. So this is another case. She's much younger, 59 years old, female, and she suffered a fracture. So the problem of this patient, she's very obese. She's 164 kilograms with a little bit above 152 centimeters. She has diabetes, and she's on the psychiatry department. So she's on medication. She's doing quite, it's a nice lady. She's very nice, but sometimes the compliance is maybe a little bit less. So she had surgery in a tertiary, not in our hospital, in a tertiary hospital. And here's the CT scan. It's a two-part fracture. So maybe some of you ask yourself, why did you do surgery at all? Well, they did surgery, put in a nail. It looks like, okay, the nail is in, it is anatomically reduced. But then the patient was referred to us 6 months after this procedure because of huge femoral head necrosis. CRPs was elevated, and there was a chronic wound here at the nail entry point, and there was always coming fluids from this part. So the implant had to be removed, completely debrided. She got a spacer specimen, but we found no bacterium. There was no bacterium, but the histology was positive. So histology said infection, but no bacterial growth. So she had a spacer, antibiotics by calculation, and she was doing quite well. And 3 months later, she came, CRP was completely normal, wounds was normal. So we decided, okay, so we do a reverse. We take out the spacer and put in a reverse with an allograft. And during surgery, opened up, and then what happened? There was pus inside and a small area at the subscapularis insertion. And so we decided, okay, we cannot progress with the prosthesis. We have to do another spacer. Took specimen, jet lavage, and the lady got a second spacer. 3 months later, she came again, and now this part was chronic wound again at the former nail entry point. CRPs again elevated, but still no bacterium. So we decided, okay, we have to do debridement again, and she got a third spacer. So she had 3 spacers, and so then there was the Corona pandemic, and almost 1 year after, she was running around with the spacer, but CRP was normal again, no infection signs. And we were brave, and we thought, okay, now, okay, let's go and do the reverse. We did the reverse again, took specimen and samples, and now guess what happened? The first time we get a bacterium, a highly resistant Staphylococcus epidermidis, resistant almost again all the antibiotics we have. So she had to take linezolid, which is a reserve antibiotic, for 28 days, and afterwards levofloxacin plus rifampicin for 6 weeks. And she was doing quite well. 3 months post-op, good function, CRP only slightly elevated, but she wasn't complaining. The radiographs looked quite okay. And we did a CT scan because she was a little bit too obese, so we couldn't turn her so right that we could see the base plate, but the CT scan showed there's no signs of loosening, and we thought, okay, we're done. But then 6 months later, she came and we did this radiograph, and as you can see indicated by the arrows, there's signs of loosening, and if you do a CT scan now, the base plate is loose. The stem looks quite well and is fixed. There's no signs of loosening on the stem, but the base plate is loose. We did an arthroscopy and confirmed it was completely loose. So decided after 3 spacers, she had them 1 year, long course of reserve antibiotics. The stem was well fixed. So we decided, okay, we don't going to do an allograft and complex revision, just put in an adapter with an oversized head on it. We will agree with her on the low function, and until now she has no clinical signs of infection, but we will see what happens. Okay, so this is just the summary. So in revisions, there's definitely a structured approach needed. Planning is super important. Bone defects have to be addressed with allografts and autografts. It depends on how big the defect is. Soft tissues determine the function. If there's too much defect, you will have a bad function. And maybe you will need special implants, oversized custom-made or modular implants. And if you have a big defect, 2 or 3 or multiple steps have to be planned with spacers. Okay, so thank you very much for the attention, and feel free to ask.
Thank you, Robert, for a brilliant presentation with some really exciting case examples. Absolutely brilliant work. Couple of questions, Robert. Do you think there's a role for 3D printing of implants, especially some of these complex revisions that you do?
Yes, why not? I mean, if you have a complex case and you can plan the base plate and the implant on the glenoid side, and you can print it on a metal printer, and then just put it on there, you will definitely get maybe a good fit and a good primary stability. But the big problem is it's bulky metal. So the less metal, the less surface you have, the better it is. So in my hands, or let's say from my perspective, I wouldn't promote 3D printing too much because the metal part is too big. So from my point of view, it's good to have a long and thin central pack, an anchor. This is when you get this fixed well in the native bone and you put in an allograft, which can grow in, and there's biology which connects to the original, to the native bone, then you have a much better long-term result and ingrowth as compared to a printed version. But there's no hard data to rely on. You know, I just tell you this by my opinion. This is not evidence-based.
Thank you, Robert, for that. And how often have you encountered this Cutibacterium acnes? And what is your treatment strategy? You go for a single stage, or what antibiotics do you prefer?
Well, Cutibacterium, it's a mystery. You know, it's such a strange thing, and nobody really knows. So there's, you know, my colleague from England, Arthur Levy, told that maybe this is the cause of osteoarthritis, which sounds too crazy to be true. I mean, why a bacterium should make osteoarthritis? It's crazy. It can't be, you know. But we find Cutibacterium so often in healthy patients. So, and this is definitely because we do not get the disinfection into the deep layers. We don't get it there. So once you cut in, you have it. And then it depends how much bacteria you will displace. And, you know, I mean, in the study series we did, there has been almost over 30%, 1/3 of patients. We did primary surgery, open surgery, arthroscopic surgery. More than a third had Cutibacterium. We found it in the deep layers, in the super, everywhere. Okay, how many of them did have a serious infection?
Okay.
None. So we find it, but in some cases it's a pathogen, and in some cases it's not. So we thought, why is that so? So we took super healthy patients and took just a specimen arthroscopically, and we found it intracellular in the joint. So this was a series of 23 patients. I don't know if this is true. I mean, but we found it. So if this is really true, this means that the bacterium is like part of the microbiome which lives there. And in some cases it does something, and in others it does not. So it's an immunological question. So if you're going to implant a prosthesis into a bed of bacteria and it doesn't do anything, so we do just a good disinfection. We take iodine and we try to work pretty good with soft tissues, and we yeah, we have also infections, but I think it's okay. So what to do if you have a really infected shoulder with Cutibacterium? So there's definitely a biofilm, and you have to take out all remnants and all foreign material. So if there's a loosening and a clear infection with Cutibacterium, everything has to go out, and you need a spacer. And usually Cutibacterium is quite susceptible for antibiotics, so beta-lactams are working quite well. And if you implant the final prosthesis, we combine it with rifampicin.
Thank you, Robert, for that. Also, Dr. Jaya Venkatesh is also in the Zoom room. Jaya, your questions to Dr. Hudeck.
Yeah, first of all, Hudeck, it's a wealth of information you have with a lot of clinical data. With Professor Golke, you should write a book on revision procedures of arthroplasty. I have a question. You have shown that you did arthroscopy in patients with reverse shoulder or some kind of shoulder prosthesis. What are the indications and why do you do that?
Well, if you're not, I mean, arthroscopy is a good tool to get samples. You can try to, if you are not sure if there's an infection, if you have a bacterium, you can try to penetrate the joint with a needle, sterile needle, and aspirate something. But this is not very reliable. So in our hands, for anatomical shoulders, you definitely should do it if you are not sure, because you see with arthroscopy, you see two things. You can get fluids, and you get histology. So histology, you can ask the pathologist if there's a sign of an infection. So if you have a positive microbiology plus a positive histology, you can say it's an infection. If you have only a positive microbiology but no positive histology, it's not as sure as you thought it to be. And the second or more thing you see is the glenoid. So if there's pistoning. So there's so many cases with patients who are painful. You make a radiograph, you make a CT scan, everything looks perfect. You think, why is there pain? So you make an arthroscopy and you can push a little bit on the poly of the glenoid, and you see it's moving, it's pistoning. So that's the reason for arthroscopy. And in a reverse, you would also, it's quite difficult to get into the joint with the arthroscope when there's a reverse, but you can also aspirate fluids pretty well and you can get a histology.
Yeah, thank you.
Any more questions? That's all the questions that we have, Dr. Hudeck. Fantastic lecture. And I'm sure this lecture is going to benefit a lot of shoulder surgeons all over the world. Thank you so much for joining in.
Yeah, thank you very much for your invitation, and many thanks also to Frank Olke, who was my mentor, who did all these cases you have seen. So almost all of them not done by me, but by Frank Olke, and his concepts are also yeah, it's his part of work. So